Chapter 9, Part 3, Patient Assessment, the Gathering of Vital Signs. We've been over how to obtain. We're not going to talk about how to document. We're not going to talk very much about how to use our various monitoring devices, because gathering of vital signs and actually checking our patient's heart rate, respiratory rate, blood pressure, skin color, temperature and condition, and pupillary response are things that you're going to be expected to be able to do manually and do appropriately. We can't talk about using all these fancy tools if we can't actually verify and perform the physical task all by itself before we get into that. What are our vital signs? Why are they important? This top bullet point should be your take-home message. It is the outward depiction of what is going on inside of our person. When we get vital signs, they are called vital signs for a reason, because they are showing us how all of the body's vital functions are actually being accomplished. It's going to help us trend our patient condition. So what I'll tell you is one set of vital signs doesn't often tell you very much, because you don't have any idea what this patient's blood pressure or heart rate or respiratory rate are normally. Our first set of vital signs that we take are called our baseline vital signs. And every subsequent set of vital signs that we check on our patient from that point on help us to identify a trend in their condition. If their vital signs aren't great, so maybe they're hypotensive, maybe they're tachycardic, maybe they have a high respiratory rate and they are tachypneic. Tachy meaning fast, pnea meaning breathing, so fast breathing. Well, okay, that tells me a little bit with my baseline set, but hopefully when I get there and I start providing my treatment, maybe their blood pressure doesn't change any, maybe their heart rate doesn't change any, maybe their respiratory rate doesn't change any. They're not getting worse, so the trend is that they are actually maintaining their current level of sick. If I show up and I give my patient epinephrine after I find them in anaphylaxis, and their blood pressure gets better, and their respiratory rate, rhythm, and quality gets better, and they start doing the things as a person that they need to do to remain alive, well, now I'm identifying a trend of their condition getting better. There's plenty of times where we can identify a trend of our patient getting worse. We are going to take vital signs, at least 2 sets on every single patient that you come into contact with from now until the end of time. They're saying here in the bottom bullet point that sometimes patient severity and treatment priorities may prevent acquisition. That's somewhat true and somewhat not, because regardless of how sick someone is, you're going to be looking for their respiratory rate. You're going to be looking for their heart rate. You can make some sort of guesses at what their blood pressure is like, depending on the different spots where you can actually feel a pulse. In order to have a palpable pulse in your patient's radial arteries, they have to have a blood pressure of better than 90 millimeters of mercury systolic. So their top number, their systolic blood pressure, has to be over 90 for there to be enough pressure in their cardiovascular system for you to feel a pulse there. That means they are perfusing. They might not be perfusing well, but they are actually circulating blood. And we can, depending on how close and how far away from the body, we can make guesses, and I call them guesses, but they're educated guesses at what their blood pressure is. So really, there's not much excuse for not checking your patient's vital signs. The big ones we're always looking for: pulse, respiratory rate, blood pressure, and skin color, temperature, and condition. These are going to tell me a whole awful lot. Yeah, do I shine my pen light in the patient's eyes if I think they have a head injury or if I think they're having a stroke or something like that? Sure. But I don't always check pupillary response on every single patient. You know, some of these things are going to be not done on everyone, because checking a blood sugar is a vital sign. So getting a finger stick and providing a blood sample so that I can tell how much sugar is in my patient's blood, I'm not going to do that on everyone. I'm going to do that on everyone with an altered mental status because I know low sugar or high sugar cause an altered mental status. It might not be what's altering this patient's mental status, but if I use that as one of my vital signs and I prick their finger and I check their blood sugar, it will tell me something. Either their blood sugar is all jacked up and it could be the cause of their altered mental status, or their blood sugar is normal and I can cross that off of my list of probables. Because if my blood sugar is normal, it's a normal finding, it's not going to be the cause of their alteration. And we can look at some of the other vital signs in the exact same way. If my patient has a normal blood pressure and they have a normal heart rate and a normal respiratory rate, but I'm still seeing some sorts of problems with them, it'll tell me either what they could be sick with or just how sick they are. Because the body's going to use some internal measures, some things to compensate that will actually have these blood pressures and pulses and respirations and all of that maintain a somewhat normal level in the early stages of some medical and traumatic events. What are we actually feeling when we touch and feel our patient's pulse? It is the actual palpable pressure that can be felt throughout the vascular system every single time a heart beats, causing a pressure wave to move through the arteries. So every time you put your finger on a patient's pulse and you feel that little bump, that is the ventricles in that patient's heart squeezing and ejecting blood into the vascular system. Where can it be felt? Well, the short answer to that is just about everywhere. Any single place that you can compress an artery over a bone, you can check a pulse. When we did CPR, we talked about checking brachial pulses on our infant patients because they have those pudgy little necks and it would be next to impossible to find their carotid arteries. So we check a brachial. You look at the picture right here. This EMT is checking a radial pulse on this patient. And depending on where you're checking is going to tell you what is going on with your patient. Because it's entirely possible you could check a radial and a carotid pulse in your patient's neck on the same patient and may feel different things. You may feel next to no pulse or a pulse that feels like it's going away in your patient's radial artery, but you could have a nice rapid and strong carotid pulse. And all of that is based on pressure. Our cardiovascular system runs on pressure. Your heart functions as a pump, the blood is the fluid, the vascular structure itself is the pipes, and as long as those three things are playing well with one another, you will be able to feel pulses just about anywhere you want to check. We're counting beats per minute. When we talk the law of averages here, normal pulse rate for an adult at rest is between 60 and 100. If we have a rate that is above 100 beats per minute, we're going to call that rapid. Our rapid pulse is also known as tachycardia. Tachy, fast, cardia is heart rate, so rapid pulse. If our patient has a heart rate that is below 60 beats per minute, that is considered to be slow. Slow is what we call bradycardia. Brady being slow, cardia being heart rate, slow pulse. Now, a lot of these vital signs are going to be based on how healthy your patient is in general. If you show up and you are working a standby for a detail at a track and field event, and your patient has a heart rate in the 40s, guess what? That's not symptomatic for him. That's not pathologic. He's not having a problem. Because if your patient is in very good cardiovascular shape, they don't need to breathe as fast. Their heart doesn't need to beat as fast. It gets used to being really well taken care of and slows down a little bit. It is entirely possible that, well-conditioned athletes will have a heart rate in the 50s or in the 40s and be perfectly fine. So when we pair these vital signs and all of our patient assessment together and we form a picture of what's going on, our whole picture is inclusive of the vital signs and all the information that we have. Now, if same scenario, we're at some sort of Olympic trial and my patient has a heart rate in the 40s, but also has no blood pressure and is altered, now we're talking pathologic, because that bradycardia is forcing a low blood pressure, is forcing an altered mental status, and that 40 beats per minute is no longer possible to sustain this patient as a person. So their vital signs are pointing me towards, yes, they are having a problem. Whereas if they were just walking around, mentating normally, perfusing normally, had a normal blood pressure, and they had a heart rate of 46, it's not time to panic and start getting out the defibrillator and getting ready to work a cardiac arrest, because they probably always walk around like that. The time to worry or the time to be concerned is when your patient has a heart rate above 120 or below 50 and is symptomatic. Now, 120 is really, really fast, and 50 is really, really low. But if you took my heart rate after I ran around the block, do you think my heart rate would probably be above 120?
Yes, could be, possibly,
It would
depending on how.
absolutely be above 120, and I'd probably be having chest pain too. So use all of this as a tool, right? If your patient is sitting there and tacking away at 120 and has been sitting in their lazy boy recliner all day, well, that's probably problematic. If your patient just got off the treadmill and is complaining about, I feel like I pulled a hamstring or maybe I tore a groin muscle or something, and their heart rate is above 120, and you get there minutes after the problem, 120 is probably not a significant finding. Compare it to your next set of vital signs and try to identify a trend. Did that 120 beats per minute come down a few minutes later? When we are identifying and checking our patient's pulse, we want to look at a couple of things. Rhythm and force. So your average patient's heart rate should be nice and what we call regular. It should be very marched out. There should be an equal amount of space and an equal amount of time between each beat. Bump, 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 bump. Because if it's irregular, that means the heart muscle is irritable for some reason, because the beats aren't coming off very marched out like they're supposed to. And then force is exactly how much pressure do you feel? Does it feel nice and strong? Do you feel every beat just kind of thumping away in your patient's chest? Or does it feel kind of weak when you touch it? Or does it feel like it kind of disappears? And if you find any irregularities with their rhythm or their force, you're going to be able to just keep a little bit of information in your back pocket at that point, because you can pair some of that with, all right, does my patient have a cardiac history? Does my patient have high blood pressure, low blood pressure? Are they having or complaining of some form of cardiac type pain? And it gives us a point of reference for, all right, this is what I felt and this is what I found. When we check our patient's vital signs, it is very infrequently that we actually sit there for an entire minute and count every heartbeat. Let's face it, you got into emergency medicine because, you like to be on the move. Nobody says, I'm going to be an EMT and I want to sit at, the check-in desk at a doctor's office all day long. When we are going to check our patient's pulse, There's a couple different ways to do it, but you can either count for 30 seconds and then multiply that number by 2 to get how many beats per minute, or count for 15 seconds and multiply that number by 4 and get your actual beats per minute. Rhythm and quality, so rhythm and force, are just things you're going to get by feel, as well as that number. What are some times you think you might actually, instead of only counting for 30 seconds or 15 seconds, what's something that might make you think you should count for an entire minute?
An irregular heartbeat?
All right, I'll take that. An irregular heartbeat. A couple of the other times that you might want to check for longer is if their pulse is extremely fast or extremely slow. Because let's say my patient's heart rate is only 30 beats per minute. That is 1 beat every other second. So if you only count for 15 seconds and multiply that by 4, it's entirely possible you've missed somewhere between 8 and 10 beats per minute. So if your patient's heart rate is really fast or really slow, count for an extended period of time to get a more accurate number. Because when a patient is sick, it is fairly important to actually get the correct number and make sure you are in the right ballpark, because there is a big difference between, 120 beats per minute or 160 beats per minute or 180 beats per minute, or the flip side of that, 30, 40, 50 beats per minute. So make sure you're getting accurate numbers, because we can't do much to correct how fast or slow a patient's heart rate is. But our paramedic partners might show up, and based on the numbers that we provide them for heart rate, respiratory rate, and blood pressure, they may actually start doing some pretty significant, pretty invasive type treatments, and it pays to be right for both parties involved. When we're going to count our patients' respirations, there's a couple of things I want to tell you about this. You know how I said we don't count for the entire minute when we talk about pulse? When you're checking your patient's pulse, leave your fingers on that radial pulse that you're checking, because we don't just go running up and jamming our fingers into the neck of a patient who's conscious and alert. So if your patient's awake and talking to you and you're checking their radial pulse as part of your vital sign check, do your 15 seconds, multiply that by 4, and get your heart rate beats per minute. And then leave your hand there. Because the minute your patient figures out that you're counting their respirations, they're going to change the way that they're breathing, and it's going to mess up your numbers. So if you leave your hands like you're still checking their pulse, but then instead just actually count the amount of times that their chest goes up and down in the next 15 seconds, you've tricked them, and you actually get a decent evaluation of their respiratory rate. You're going to do the exact same things for heart rate and respiratory rate when we're talking about numbers. We want rate, rhythm, and quality for both. One of the additional things we can do for respirations is listen to our patient's lung sounds. I can't stress enough how important it is to actually check your patient's lung sounds, because with a lot of the medical conditions we can treat as EMTs at the basic level, lung sounds are going to tell us everything we need to know and give us a really good look at our patient. And they take almost no time at all, and they give us the keys to the kingdom. When we check a respiratory rate, rhythm, and quality and listen to a set of lung sounds, we are going to have so much information right off the bat that will absolutely prove very useful in treatment and possible medication of our patient. Our normal respiratory rate, 12 to 20 breaths per minute, the same as with a heart rate. age, sex, size, physical conditioning, emotional state, or respiratory need. So again, if I was running around the building here, I can assure you my respiratory rate would also be higher than 20, but I also probably wouldn't be in respiratory distress. I would, stop running and my respiratory rate would return to normal when you reassessed my vital signs to identify that trend. When we start to be concerned as far as respiratory rate numbers go, it is going to be a respiratory rate of above 24 or below 8, where we start thinking that those are pretty significant findings. A respiratory rate of above 24 generally doesn't give the patient enough depth, so enough quality of respirations. We don't see the chest rise and fall the way that it's supposed to. And if my patient isn't filling up their lungs and getting all this oxygen-rich gas down into their alveoli, no gas exchange is taking place, no perfusion is going to happen, and my patient's respiratory condition is going to worsen. Excuse me. The same goes for if my patient's respiratory rate is too slow. If their respiratory rate is below 8, generally, they are not breathing fast enough to provide enough of that oxygen-rich gas to carry out the job of being a metabolic machine and survive as a person. So we need to start figuring out, hey, do I need to ventilate this patient? Hey, do I need to add more oxygen to this patient? What can I do to fix this respiratory issue that is causing my patient to breathe 30, 40 times a minute or 6, 7, 8 times a minute? When we talk about breathing, it should always be noiseless, effortless, and painless. If we have any of those things when our patient is complaining about a respiratory issue, we are going to have some form of respiratory distress and probably some sort of rate, rhythm, or quality disturbance. So when we categorize breathing, it's either normal, shallow, labored, or noisy. So normal, that's great. If you looked around your house at the people that are around you, or even looked at yourself, you could probably categorize your respiratory rate as normal. Shallow means the chest isn't moving enough. If the chest isn't moving enough, we're not filling the lungs enough. And if we're not filling the lungs enough, nothing of any use is happening. Labored falls into that effortless category. If you watch yourself breathe, it doesn't look like a lot of work. It shouldn't look like a lot of work. And if we look at a patient and we are starting to see some use of accessory muscles or nasal flaring, or it just really looks like it's a ton of effort for them to get air in and out, that's problematic. And we need to figure out where we can create some sort of positive result with some of the treatments that we have available to us, whether it's just oxygen, ventilation, medication, transport and getting them to the emergency room at a reasonable amount of time, and then noisy. Breathing should not be noisy. Anytime there is any noise involved in your patient's breathing, you've identified a problem. It's not always going to be a problem we can fix, but it is always a problem that definitely bears our attention to see if there's anything we can do about it. And the last little bit of really super important that we're going to talk about is skin color, temperature, and condition. Skin color, temperature, and condition, much like our lung sounds, are going to give us such a huge jumping off point and such a large amount of information with almost no work. It's practically free. If the body is under stress and the body is under duress, it will make some very important decisions without any input from our patient and decide what it's going to supply blood to and what it's not. And one of the first outward signs we'll see of a patient who is not perfusing well, or who is not breathing well, or who is having some sort of oxygenation, ventilation, heart rate disturbance is going to be changes in their skin color, temperature, and condition. As a general rule, we want to see people pink, warm, and dry. That is the perfect skin finding. Now, when we talk pink, warm, and dry, we're talking mucosal membranes, general skin feel, and people shouldn't be hot or cold. When you touch a patient, it should feel like next to nothing. If a patient is really super cold or really super warm to the touch, you've probably, without even another bit of lecture, identified someone who either A, has been in the heat too long or in the cold for too long, or B, has developed some sort of septic infection, which we'll talk about tomorrow when we talk about shock. Color, temperature, and condition is going to tell us, without any shadow of doubt, of our patient's perfusion status. Because if your patient is anything other than pink, warm, or dry, it's wrong. Period. No questions. If we look at my patient's nail beds, or the inside of their cheek, or underneath their eyelids, or on someone with light complexion anyhow, and we see any of these colors that you're going to see next, pale, cyanotic like a blue-gray, flushed like beet red, or red splotches all over them, or yellow like the color of the highlighter that you guys use to highlight your textbook. Does that sound normal?
No.
Yeah, we'll just keep this in the department of common sense, right? Pale, they're going to look sick. Blue, gray in color, you look at that patient, you go, wow, what's
You
keeping
can't
them
breathe.
alive, right? They just, people when they don't look right, really tend to look awful. And that's what we're talking about here with this quick skin color, temperature, and condition. It's not meant to take forever. It is really not meant to be this great big giant hassle. You look at your patient and go, do they look normal? Do they not look normal? And it's really that eyeball decision that's really easy to figure out. Now we're going to talk capillary refill. When we're talking perfusion status, and especially if we're in a hurry, capillary refill is going to be something that can give us some decent information, albeit not always the most accurate. Capillary refill is when you take your patient's fingernail and you squeeze it, and you'll watch that the pink in their nail bed goes away. And then within 2 seconds, generally, would be a normal finding for that pink color to return. What you're doing when you check capillary refill is you are forcing all of the blood out of those capillaries in the nail bed. And it should take less than 2 seconds for that blood to return. That's a positive finding. If we find that their capillary refill is delayed, that means they are not perfusing to their end tissues as well as they should be. It doesn't tell us why. It doesn't tell us what their blood pressure is. It just tells us, is the heart forcing blood as far away from the body as it can every second of this patient's existence? This is a really good test for pediatric patients. Any patient under the age of 3, we don't really even normally check a blood pressure on. So we would check a capillary refill, and that would tell me whether or not they had enough pressure based on a couple of my other vital signs, like heart rate and respiratory rate. But generally speaking, don't sort of substitute capillary refill for actually taking a real for life physical blood pressure. And now our pupillary response. Here is our normal findings for a patient's pupils. When we look in their eyes, obviously the center black of their eye is called the pupil. In a dim environment, so probably pretty much even the rooms that you guys are sitting in right now listening to me, If you take a light and shine it into your patient's eye and then remove it, you'll watch the eye dilate when the light goes in and then constrict back down to normal when you remove the light. That's a normal finding. If you're in a bright environment and you cover the patient's eye, you will see a pupil that is constricted because the environment's bright. When you cover it, you'll watch the pupil dilate. And then when you remove your hand again, you'll watch that pupil constrict back down. That's a normal finding. The pupil adjusts to the amount of light it's exposed to. So in a dim environment, if you put something bright there, it gets smaller. And then it opens back up when you remove the light. In a bright environment, if you make it dim, it will get big and then it will get small again. Patients who have some pretty significant neurological impairment or have a head injury, a stroke, or plenty of other problems will have problems maintaining their pupillary size and reactivity to light. We are looking for the pupils to be equal, round, and reactive to light. And let's take a look on this next slide at some things that are going to look a little different. Our constricted pupils. Constricted pupils are generally someone who has overdosed on some form of narcotic medication. This is a central nervous system depressant overdose, so everything's been turned down. The pupils are constricted way down. They look like little black flecks of rice in the middle of our patient's eyes. Dilated pupils, this can be anything from some form of stimulant use to a dead patient. Generally, when we die, our pupils will become fixed and dilated. So when we shine a light in this patient's eyes, it will do nothing if they are deceased and in cardiac arrest. And then unequal pupils down here on the bottom. They got a little from column A and a little from column B. One pupil's dilated, one pupil's constricted. Maybe they're just unequal and really kind of reacting differently. That can mean any host of issues are going on, none of which are good for our patient. Pupils, when we have significant findings with our pupillary response, they all mean some pretty negative stuff. Dilated and fixed is generally cardiac arrest, like I said. Just dilated but reactive is generally drug use, some form of stimulant or other altering substance like LSD. Constricted, it's generally some form of central nervous system disorder where the central nervous system has been turned off. And a lot of the times we see it for narcotics. That's going to be one of the big things we look for. Unequal is stroke, head injury, trauma. Some types of eye drops will do it. Or if your patient's conscious and alert and speaking to you normally, sometimes it just means they have a glass eye. And last but not least, non-reactive is also about as negative could get, because we're talking cardiac arrest, significant brain injury, or overdose. Let's see what's left. Blood pressure. All right, the rest of that will be part of today's lab. So, Chapter 9, Part 3, we have accomplished. Anybody have any questions about vital signs? I mean, we've been doing them since, what, almost the first day of class, right? Maybe the second. All right, so lastly, we're going to get into patient assessment and assessment of our medical patient. We're going to take another short break. We'll talk in 10 minutes. So I'm going to put 10 minutes up on the screen. And from here on out, we're going to talk patient assessment and now finally actually getting into the nuts and bolts of assessing our patient. When you guys come here today, we'll do a little bit of lab on blood glucose monitoring, patient assessment, pharmacology, you name it, we're going to get into it today. But let's take another short break.
Thank you, guys. Thank you.
God bless.
Oh, thank you.
All right, we're back and we're going to talk patient assessment now. We have finally gotten into the full-on bit that we're going to get into that's going to tell us what is wrong with this patient and what, if anything, can we do to fix it. So I'm going to pass out later on today some of the patient assessment stuff, for lack of a better term, that we're going to go over. This sheet being one of them. Now, some of this is going to be a little bit of review, because if you look right at the top, we have scene size up and initial assessment. So our scene size up is all the things that are going to keep us safe. Our scene safety, our BSI, our making sure that, whatever mechanism of injury or nature of illness that is going on with our patient is not going to affect us. So we start looking at what could be wrong with the patient. Do we have more patients than we can care for? Do we need any additional resources? If it's a traumatic event, do we need to consider the need for spinal immobilization? All of that, great, good stuff. And our initial assessment of our patient is when we finally make contact and we see them for the very first time. And we are going to start looking at things like our general impression. What does this patient look like? Do they look like someone who's having a problem? That can tell you some information. We're going to get our AVPU scale and our level of consciousness. So alert, verbal, painful, or unresponsive. Then I'm going to ask them those 4 questions. Do you know who you are? Do you know where you are? Do you know roundabout what day or time it is? And can you tell me what's going on? Because it's not enough to know, is my patient conscious? Now I want to know, is my patient capable of being involved in their care? Do they have enough mental status and awareness to tell me what's going on in a way that I can actually use that information? Then I'm going to assess airway, breathing, and circulation. Airways need to be open, clear, and secure in order for me to call them patent. I'm going to check breathing, rate, rhythm, quality. I want to ensure that it is noiseless, effortless, and painless. And I'm going to move on to circulation. I'm going to check rate, rhythm, quality again, and skin color, temperature, and condition. And if I find a problem with any of my patient's general impression, mental status, or airway, breathing, or circulation, it is absolutely, without a shadow of a doubt, a sick patient, because those are the things that are going to keep that person alive. They need to have a proper mental status. They need to have an open, clear, and secure airway. They need to have an adequate respiratory rate, rhythm, and quality, and they need to be circulating blood appropriately. If you found a problem during your primary assessment, it is a primary problem. It is yours to fix right that very second. You don't move on. You do not collect $200 until you correct problems that you found in your primary assessment. But it also helps you make your transport decision. Your transport decision is going to be that they are a priority patient that you're going to transport to the closest appropriate facility with an ALS intercept en route. Period, end of story. You haven't figured out what's wrong with this patient. You haven't actually really assessed much, but you've found what you've determined to be a primary problem, and that primary problem needed managing. And after you manage that primary problem, now we can get into actually figuring out what on God's good earth is wrong with this human and why did they call 911? When we are assessing a responsive medical patient, someone who is able to communicate with us, someone who can tell us a story that makes sense, we're going to focus on their chief complaint, because they're going to tell us when we say, hey, what's going on today? Boy, my chest hurts. Okay, that tells me something important. My patient called 911 for chest pain. And then I start running through in my mind while I'm asking them the follow-up questions that'll be coming at us here in just a couple seconds of what can I do for this patient's chest pain? What's in my toolbox? What tricks of the trade can I bust out if we get to a point where I can medicate this patient? Can I do that with an unresponsive patient?
No.
No, so I have to base all of my decisions And all of my assessment on physical findings, things that I find on this human or things that I witness this human doing that point me towards one problem or another. With a medical patient, it's kind of hard when they're unresponsive because it's difficult to get any decent information. You're not going to find broken bones. You're not going to find signs of trauma. You're not going to find a lot of useful information all the time. But if we start at the top and work to the bottom through our physical assessment of this patient, at least we can say we didn't miss anything. When you perform a physical exam on a patient who is unresponsive, it's done in head to toe fashion. We start at the top, we work to the toes, and we palpate and look at and touch and poke and prod everything in between. And maybe we find something, maybe we don't. It is so much easier to assess someone who can talk to me and tell me what it is that's going on and what it is that's bothering them. After we do our primary assessment, so we've done our scene size up, we've done our primary assessment, now we are going to get into what's called our secondary assessment of the patient. Our secondary assessment is where we actually figure out what is going on with this person. We're going to ask them questions. We're going to talk to them about their medical history. We're going to talk to them about their current history of present illness and get into what is it that's happening and can I do anything about it? We gather a set of baseline vital signs, and that tells us whether treatment is indicated or treatment is not indicated. And then when we get to the end, we treat the problem and we transport. And then as we're transporting, we're going to go back and reassess. You don't just sit there on your hands and look at your patient and go, all right, we'll be to the emergency room in a few minutes. We constantly go back and evaluate. We reevaluate the things that we've done. We start our reassessment of every single patient right back at the beginning, right at the primary assessment, to make sure that their problem's not devolving now into a problem with airway, breathing, or circulation, and they're not getting sicker. We go right back through and check our interventions and make sure they're all still working. And assessing a patient is fluid. It is something that is continually going the entire time you are next to that patient, whether it's standing in their living room or sitting in your ambulance. You are constantly reevaluating this patient. When we're questioning patients or talking to bystanders, if the patient doesn't know or can't help us with the information we're looking for, we want to ask yes or no questions. I mean, we don't want to ask yes or no questions. Sorry, we want to ask open-ended questions. Why don't I ask questions that can be answered in yes or no fashion?
It gives you little to no detail on what the issue is.
Right. If I say to my patient, are you having chest pain? Are you having difficulty breathing? Do you have a bellyache? All I'm going to get is yep, nope. If I say, what does that pain in your chest feel like? They're going to tell me something in their own words. Apologies, man. That is actual useful information. Just being able to go, yep, nope, helps me not at all. So make sure you're asking questions that they actually have to think about and formulate a response to, that they can't just give you yes and no answers to. And these are the questions that we ask. We want to know the onset. How did this problem start? What were you doing when this all kicked off and began? P, provokes. Does anything make this pain better? Does anything make this pain worse? Quality. Can you tell me what it feels like? Describe the pain for me. Radiation. Where is it and does it go anywhere? Does it move around? Pain a lot of the times, or discomfort, or whatever the patient terms it as, will follow along neurological pathways. The body is wired like a house, and all of that electrical current starts in the brain, travels along the spinal cord, exits the spinal cord, and passes through any amount of tissue to get out to where it's going. So anywhere along that line, there can be pain, there can be problem. We expect certain types of pain, certain types of issues to have some sort of radiation. Next is severity. How bad, on a scale of 0 being no pain at all and 10 being stepping on a Lego in the middle of the night, how uncomfortable does this make you? T stands for time. When did it start? So think of OPQRST. We try to keep things simple, and the alphabet is about as simple gets. Onset, provoke or palliate, quality, radiation, severity, or time. The last little bit of information we can try to get is, did you or anyone else try to do anything to make this better? A lot of the times you'll get that with provoke and palliate. They'll say, oh yeah, normally, I take my inhaler and it clears this up, no problem. All right, well, did you take your inhaler? Well, yeah. Did it work? No. Okay. We're getting more information. We're building our case. We're gathering our story. And this OPQRST is the history of the present illness that allows us to do that. This is part of our examination of our conscious patient. One of the other tools that we use is another mnemonic to get our patients past medical history. Because knowing things that they have going on that are chronic problems or stuff that has happened to them in the past is oftentimes a pretty good indication of what may be coming for them in the future. So one of the first things we talk about is signs and symptoms. Anybody out there know the difference between a sign and a symptom? Well, let me ask you this.
Oh, sign.
No, I do.
All right, let's hear it then.
A sign is when you look at somebody. So like if I'm looking at her and I see her like blue or I see them retracting, that's a sign. A symptom is them telling me my symptoms, like my stomach hurts or I feel bubbles in my in my stomach, that kind of thing.
Perfect. A sign is something that I can see. A sign is something that I look at and it looks right back at me. A symptom is something my patient has to tell me. It's something going on inside of them that they feel or see or hear. So signs you can actually visualize, symptoms are something that they're telling you. I'm going to ask them what they have for allergies. I want to know food, medication, you name it. Are you allergic to anything? As far as medications that we are going to give a patient, allergies aren't a huge, big, all-encompassing problem. But as far as when they get into the emergency room and things like that, they could wind up on some medication that, if they were allergic to it, would make them have a very negative outcome. The P in our sample history is pertinent past history. Why is that pertinent word so important?
The permanent past history?
Yeah, why is the pertinent part of that important?
Because we want to know what they suffer from and what kind of medications have they been on in the past or in the recent 2 days, like, for example, the nitro.
Yeah, the pertinent portion of that is the important part, because do you really think I care that 25 years ago they had their wisdom teeth out, and 15 years before that they had an appendix removal, and 5 years before that they had to have their tonsils out? All right, now we're talking like 40 years ago. This is an emergency. You called 911 because this was emergent. Yes, when we get into the ambulance, if you want to tell me about when old Doc Johnson came to the house and cut everyone in the family's tonsils out, great, tell me all about it. But right now I want to talk about your chest pain. Do you have any history of high blood pressure? Do you have high cholesterol? Do you have type 2 diabetes? Have you ever had a heart attack before? When we're getting our sample history, we want to know the things that are pertinent to their chief complaint. They can tell me anything and everything they want to tell me when we get to the ambulance and we figured out what's going on with them, and I've treated it and I've stabilized their condition. But I really, unless your appendectomy was a week ago and you're now having a fever and abdominal pain and blah, 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 that's not pertinent to what's going on right this minute. I want to know the last time they had anything to eat or drink, and the last time that they actually used the restroom, and was it normal? Because that's going to tell me some information that I'm going to pass along. Now, it's not super, super important for me in my treatment of this patient to know when was the last time you had a meal and when was the last time you used the toilet and did everything go okay. But keep in mind, our patients don't always get better. A lot of the times our patients will get worse. If our patients get worse, maybe they wind up unresponsive. You might be the last person that ever speaks to this patient before you get them to the emergency room. So all this information needs to be gathered, and it needs to be gathered on every patient, because the emergency room staff and the doctors or the surgeons or whoever else they may need to see might not get an opportunity to talk to them. So getting all of your OPQRST and your sample history are going to be important things moving forward. And this is actually part of the checklist that the state uses to grade you when we get into prepping for our practical exam. You have to ask about onset, provocation, quality, radiation, severity, time. You have to ask for their signs and symptoms, their allergies, their medications, their pertinent history, the last time they had anything to eat or drink, and the events leading up to their problem. Because it shows that you are able to actually know the questions to ask the questions, retain the information, and most importantly, when we get to checking our vital signs and deciding on a treatment, providing the appropriate treatment for this patient.
What's that last one? Risk factors.
So risk factors is
that because of COVID?
no.
I don't
Risk
remember that from last time. That's why.
factors is a bit of a new bit of information that we're looking for. So when we ask about risk factors, or maybe don't even have to ask about risk factors because they're going to tell us what some of them are. You know, do you smoke? Do you drink? Do you do drugs? Do you have a cardiac history? Those are all going to be risk factors. Those are all things that we expect to exacerbate and make certain medical problems worse. So sometimes we don't even need to ask that. You know, all right, my patient told me they have hypertension, they have type 2 diabetes, they're overweight, and now they're complaining of chest pain and they've had a heart attack before. Those are all the risk factors that we expect to cause further cardiac compromise. So our secondary assessment of an unresponsive patient, sure, we're going to get a chief complaint. When we get dispatched, somebody's going to tell us that, hey, there's something wrong with someone at 123 Main Street, City of Malden. Okay, if my patient's unresponsive and can't tell me anything, chief complaint is my dispatch information. I was dispatched for an unresponsive patient at 123 Main Street. The chief complaint, to the best of my knowledge at that point, is unresponsive person. I don't have any more information. My patient's not speaking to me because they're unresponsive, so I don't have the ability to get any more information from that person. But what I can do is ask any bystanders or any family or anybody who is with that patient some of those OPQRST and sample questions. If they have the information, great. If they don't, all is not lost, because I'm still going to do a rapid assessment of that patient's entire body. I may cut their clothes off and leave them right there on my stretcher in nothing but their birthday suit and a smile, because I'm looking for what the problem could be. And I'm not allowed to miss that. If there was something to be found, if I see a cardiac implanted defibrillator or a medication patch or a medical alert ID tag on this person. Just saying, oh, well, I didn't find it, isn't good enough. So we are going to poke and prod and touch and listen and feel every single part of this person if they're unresponsive on the ground. Our unresponsive medical patient and our trauma patient get the exact same assessment. We're going to assess head, neck, chest, abdomen, pelvis, extremities, posterior, everything, because we're looking for certain signs and symptoms. We're looking for certain abnormalities. They're going to point us towards medical problems. In their
Is
neck,
this
I'm looking for jugular vein distension. That's going to point me towards possible heart failure. It's also going to give me the opportunity to look at their neck and see if they're wearing a medical alert ID tag. When I look at their chest, I'm going to look for adequate rise and fall. I'm going to listen to their lungs to make sure I hear adequate breath sounds. If I hear something like constriction and wheezes or crackling or any of the other lung sounds that we're going to talk about, that points me towards a problem. If my patient isn't telling me verbally, at least they're telling me physically. When I get down to the abdomen, I'm going to palpate the 4 quadrants of the abdomen, and I'm looking for distension, firmness, and rigidity. Any of those things are a significant finding. If you poke your own stomach right now, you poke your own abdominal quadrants, even if you're sporting a 6-pack, there's still going to be no distension. It's not going to be all bulged out and swollen. You can still push in. It doesn't feel like you're pushing on the table. So you won't have that firmness, that rigidity. If you find those things, it means that something underneath is not working appropriately. When we evaluate a patient and we get down to their pelvis, especially our medical patient, if we find any incontinence, whether it's urine or feces, that actually tells me that this patient probably had a seizure. Because generally when a patient has a seizure, that's one of the telltale things we look for if the patient is still unresponsive. So even a patient who's not talking to you has information to share with you. We just have to look for it. And then we get into our reassessment. And like I said, everything circles right back to that primary assessment. Why? Because those are the important things. Our primary assessment is going to keep this patient alive. So we go right back through our primary assessment, right back through our secondary assessment. We assess and reassess all of our interventions to make sure that they're still working. Maybe we check to make sure that we don't need to medicate this patient again with something like another nitroglycerin or another EpiPen. And then we just transport and we continue to work our way through this algorithm, through our assessment and through our reassessment over and over and over again. For a sick patient, we're talking every 3 to 5 minutes. We never stop assessing a patient who we've determined to be very critically ill or injured. If I'm just, picking grandma up at the nursing home and bringing her to a doctor's appointment, I'll probably only do those 2 sets of vital signs and I'll space them out a little bit. But if I get called for a 911 response here in the city of Malden and I show up at somebody's house, you can bet your last dollar that I am never going to stop reassessing that patient. Why do you think that is?
because you need to find out what's going on with this patient, and you want to, so you can have enough information to relate when you get to the emergency room about your patient and
Right.
what's going on.
And if somebody was sick enough to call 911 and I show up and I do my thing and I medicate them, I need to continue to evaluate this just to make sure that whatever I medicated isn't getting worse again. Just it's not the world of, like, hey, we won the game. No, the game is always still going until you get rid of that patient. So you just continue to reassess and reassess and reassess, because it is entirely likely that our patients are going to deteriorate and their condition is not going to improve. And their condition is going to need further assessment and further treatment and further intervention from you between where you picked them up and where you dropped them off. So that's why it is such a big deal to get into the habit of repeating your physical assessment, repeating your primary assessment, repeating all of the steps that you already just did, just to make sure that we've dotted all our I's, we've crossed all our T's, and this patient doesn't get sick and we miss it. All right, folks, that is it for your lecture today. I will see you all at 1 o'clock. I will put the recordings up as soon as they are finished downloading, and everything will be available to you. If you have any questions, I am going to be sitting at my computer between now and 1 o'clock, so I am available. Other than that, I'll see you guys at 1.